I'm going to talk about ACOs and how these are destroying private medical care, but we have to go back into history a little bit to see how we got here, because it's not that obvious. Now, no one has been more opposed to Obamacare than we have here at AAPS. We've, in fact, launched our own lawsuit, failed, but we tried. But it's important to understand that the ongoing destruction of private medical practice is largely due at this point, not so much to Obamacare, although that's certainly helping along, but to Medicare. And we have to go back to the beginning of Medicare and Medicaid to understand how this all came about. It was really the creation of Medicare and Medicaid back in 1965 that began this downward spiral in the quality of care and this upward trend in the cost of care. And the legislation was correctly seen at the time as the camel's nose under the tent for socialized medicine. It was vigorously opposed by Ronald Reagan, by the AAPS. We took a very firm stand against it back then. It was, of course, I was in high school at that time, but I was completely unaware that this was even going on. And of course, the AMA also opposed it. And this was, for me, the last time that they took a correct position. So there were, about the initial legislation created two parts of Medicare, Part A and B. Part C, which is managed Medicare, came much later, and Part D, the drug plan, came under George W. Bush, wonderful, wonderful president, who we miss not. Costs within the Medicare system started to rise as soon as the legislation was passed. This should not have been a surprise. And the initial Medicare was an extremely attractive program for doctors. The doctors simply submitted their charges, and they were paid 95% or so of what they submitted. It was easy, simple. A lot of doctors made a lot of money under Medicare. They sort of got bribed into participating. And the initial rules of Medicare stated unequivocally that Medicare would not interfere with the practice of medicine. And you will see how far we have come from that initial promise. So in response to this escalation of spending, which was 10 times beyond what they had predicted, no surprise there also, the government under HCFA, the Healthcare Financing Administration, which was the predecessor of CMS, started to institute different strategies to rein in these costs, but most of these took the form of price controls on doctors. Now, this was always a failed concept because, as we've known that doctors account for perhaps 10% of the pie of total spending. But doctors are such easy targets to attack. We don't have any real representation, and people see us as being wealthy and we can afford it and all this stuff. So in 1983, they began a fee freeze on Medicare payments. Since this didn't produce much, they extended it through 1986. The AMA actually went along with this, so they began their period of acquiescence to these government dictates. Now, total Medicare spending during this period actually rose. Why? Because in response to these flat fees, or reduced fees really with inflation, doctors increased volume, they ordered more tests, they did more hospitalizations, they had more consultations, they spent less time per patient, quality suffered, and costs went up. So in 1989, HCFA moved away from paying doctors based on their charges to the RBRVS, the Resource-Based Relative Value System, which is a Marxist construct that assigns dollar amounts to all the various services that doctors provide. Balanced billing of Medicare patients at that point was quite restricted. Non-participating physicians could only charge a little bit over the maximum allowable charge, and since they were also given a lower allowable rate, this increased the pressure on physicians to participate in Medicare, so Medicare increased the captive audience of doctors who were participating. In 1997, by the way, this change to RBRVS was also followed by a big increase in total Medicare spending, because the final multiplier for the fees was so low that virtually everybody took a pay cut. And of course, they passed this by pitting the surgeons versus the internists, et cetera, and the interventionalists versus the cognitive people. And of course, in the end, everybody got screwed. So in 1997, the sustainable growth rate came out of the Clinton-Gingrich Balanced Budget Act. And the idea here was to base the physician fees on total program performance the prior year. So if total Medicare spending were above a certain target, then the pay to the physicians that following year would be frozen or cut. But we've seen, and they knew, that pay cuts to doctors result in volume increases and increases in total spending. So this would have produced an ongoing downward spiral in the payments to physicians. And this is why virtually every year since the SGR was passed, there was a doc fix bill introduced and passed, usually at the last minute, by Congress to block the SGR cuts from actually taking effect. So can you imagine a more stupid piece of legislation where every year Congress has to write a fix for it to prevent it from actually working as it was intended? It's hard to imagine a more stupid piece of legislation. And as evidence that these pay cuts to doctors result in volume of service increases, Rob Lowe's, writing in Medscape, reports from the MedPAC data from 2002 to 2012, Medicare spending on physician services per beneficiary increased by 72%. A 9% increase in rates during this period was dwarfed by the growth in volume of services, including lab tests, which had a 91% increase, imaging 79% increase, and other procedures, which were up 68%. As it is, the net effect of the pay cuts and freezes has been to force many physicians out of private practice and into hospital systems. And so during the same 10-year period, Medicare fee-for-service rates increased only 9%, but the cost of operating a practice increased 27%. So over this time frame, the proportion of doctors in private practice dropped from 2/3 to about 1/3. And Ted Cruz talked about this yesterday. So if the pay cuts had been allowed to go through, the payments to doctors would be well below Medicaid levels now. So it would have actually forced physicians out of Medicare. So obviously they didn't want this to happen, so they blocked their own bill. Now this past year, not wanting to let this new crisis go to waste, the House put together this bill called H.R. 2, and then they passed it without any kind of debate. In fact, no one read it. The only person that I know personally who read it is my colleague, Chris Held, who did the heavy lifting and read through this thing the weekend right after they passed it, right? I mean, it was just incredible. So then, in fact, we were down in DC at that time lobbying for other things. And this is all they were talking about was the doc fix, the SGR HR 2 bill. But no one had read it. They had no idea what was in it. Well, it turned out it was really a disaster. And it turned into, of course, the Senate passed it also with no debate when they came back from recess. So the Medicare Access Chip Reauthorization Act, or MACRA, is a disaster for doctors and patients. It institutionalizes some of the worst aspects of Obamacare. Yes, it did get rid of the SGR, but it replaced it with more price controls, trivial updates that are going to be pulled back unless you jump through various payment for outcomes hurdles, hoops, and it furthers the destruction of private medical practice by a frontal assault on fee-for-service payment. I mean, they have made it clear that they are after fee-for-service medical practice, which is to say private medical practice. They don't want it to exist. So, for example, Section 101E of this bill promotes the alternative payment models. It creates much more bureaucracy. It sets up the Physician-Focused Payment Model Technical Advisory Committee, which by November 2016 shall establish criteria for physician payment models, including specialist physicians, and establish incentive payments for participating in such models. Money will no longer be paid directly to physicians, but only to these eligible alternative payment entities, which are, of course, accountable care organizations, medical homes, et cetera. Merit-based incentive program is going to replace the current EHR, meaningful use, and physician quality reporting, or PQRS system penalties. So physicians are then going to have a composite performance score, which is going to be posted publicly on the physician compare site on the CMS website, and it's going to be based on so-called quality, which they cannot define, of course, resource use, which means how much you're costing the system, clinical practice improvement, which I interpret to mean whether you've maintained your certification. right? Whether you're doing the jumping through the MOC hoops, and which also shows, by the way, collusion with ABIM and ABMS in the development of this legislation. And of course, the meaningful use of the electronic health record, which as we know, is reporting the clinical data to the central payers. So the physicians with a top performance score may be rewarded with a 0.5% annual update. Right, exactly, pop the champagne, right? Medicare Advantage plans managed to get a 1.5% annual increase. So, they have the money, they have the lobbying, and it paid off for them. We don't, and it didn't, obviously. So Obamacare should be seen as the last few bricks in this whole edifice of socialized medicine, except that it's not really socialized medicine in the style of the UK or Canada. It is more like the Italian model under Benito Mussolini, with heavy doses of crony capitalism or corporatism, which is, I think, a polite word for fascism. Rather than outright nationalization of industries, the government simply asserts authority over them and controls them. So deals were made with big insurance, big pharma, big hospital, big IT, and even the AMA and the AARP to buy their support. This is how it passed. Remember that Hillary Care did not pass. It was opposed by the insurance industry. They put out these Harry and Louise ads that kind of knocked Hillary Care, along with our lawsuit, of course, out. But Obamacare did pass. Why? Because of all the collusion, the crony capitalism, all the big money that went into passing this. And this is, of course, also why the Republicans, with the exception of Ted Cruz, have not done anything to defund Obamacare, because they're bought and paid for too by the center of crony capitalism. All right, so they passed this legislation without a single Republican vote, with all sorts of corrupt backroom deals to buy votes of different holdouts at the end. It was pretty disgusting. So Obamacare had several major goals: increasing the number of citizens dependent on the federal government for medical care, massively expanding Medicaid, which fortunately was blocked in a lot of states who refused to do it, magnifying federal bureaucratic control over private medical insurance and medical practice. To say that the implementation was botched would be a polite understatement. Healthcare.gov was never beta tested, and it promptly crashed. The president unilaterally and unconstitutionally changed the law many times during the rollout. One of the more egregious changes, which allowed premium subsidies to flow through the exchanges established by the federal government as opposed to the states, was upheld by the compromised Roberts Court in a legally flawed decision. And I'm sure you're going to hear much more about that from Michael Cannon, who's going to be up later. And he was one of the principal forces behind that lawsuit, which we all thought initially had a good chance. Obviously, it was an open and shut case, really, except for John Roberts. So the federal mandates for coverage, such as guaranteed issue, drove up premiums and deductibles, and most of those who were able to get policies needed the subsidies to pay premiums, and they're struggling with the deductibles. At most 10 million or so have enrolled under Obamacare, far from this mythical 50 million uninsured who were supposedly dying in the streets for lack of insurance during the whole debate running up to Obamacare. Obamacare massively expanded the federal health bureaucracy by creating over 150 new agencies, invested the Secretary of HHS with nearly dictatorial power over the entire medical industry. And it's a massive wealth transfer from younger working people and the elderly, because they cut Medicare, to a relative handful of industries and individuals. I mean, you can see it as a huge transfer payment to the insurance industry, largely. They're huge premiums, taxpayer-subsidized premiums, and high deductibles. This is just a direct contribution to the insurance industry. So what about the ACOs and bundling and payment for performance and all this stuff? Well, does anybody remember when the HMOs were being pushed? I mean, they promised to deliver higher quality at lower cost, and they failed at both. I've written that ACOs, the Accountable Care Organizations, are simply HMOs with a bad facelift, but let us examine more closely how they are different. So HMOs, or the managed care, they've been around since the 50s with the health insurance plan. They were forced into employer-sponsored plans by federal law, pushed by Ted Kennedy during the 70s. They were essentially prepaid medical care schemes with built-in rationing mechanisms. So members' premiums supported an administrative infrastructure that imposed barriers to advanced care beyond that of the so-called PCP, a new term we learned back then, the primary care provider, otherwise known as the gatekeeper. And his job was to limit the amount spent on caring for their patients. Hillary Care was intended to apply this HMO style of medicine to the entire country, as documents unearthed by our lawsuit ultimately revealed. HMOs failed because the model was flawed and only delayed care, which proved very costly. So the premiums went up, the quality actually went down, and patients found ways around gatekeepers, and many of them simply just faxed over the referrals without even seeing the patients. So the whole gatekeeper model sort of fell apart and was largely replaced by the PPO model. Now, since the HMO era, back in the 90s, there have been several key developments in the way medicine is practiced. Over the last 20 years, we have witnessed the rise of so-called evidence-based medicine. And from evidence-based medicine, thousands of clinical guidelines have been produced, largely funded by industry and largely pushing their products. And last year, we devoted the entire meeting almost to destroying the whole concept of evidence-based medicine, so we're not going to get into that here, but largely this is based on large population studies that take a trivial absolute risk reduction, let's say, and they amplify this into a significant relative risk reduction and therefore sell the drugs based on this meaningless number. And that's why tens of millions of Americans are currently taking statin drugs, most of whom can expect zero benefit from these drugs and very likely harm. And if you're one of those many millions who are on them, come see me later and we'll go over whether or not you really need these drugs. Be happy to talk to you about it. So we now have this widespread also adoption of electronic health records. This has been forced on the medical profession. Coerced sharing of clinical data with central payers, so-called meaningful use. And this is another great euphemism, which starts out slowly as a benign appearing data collection, but it is gathering steam. And the forced transition as of yesterday to ICD-10 greatly expands the clinical details that are available. So by phase 3 of meaningful use, which is coming within the next year or two, you can expect to be dealing with guideline-based algorithms designed to push you towards specific treatments. You will be forced through these algorithms by the nature of the medical electronic health record. You're going to have to click on the appropriate buttons to get paid and to be able to prescribe something. So it's going to actually guide you to specific treatments. So in other words, we are now at the point of the centralized payment and delivery of care. And the compliance with meaningful use is going to be enforced by financial penalties initially, by these scorecards that are going to be published showing your rank compared with other doctors, and this quality indicator, which is arbitrarily going to be defined as hitting your meaningful use targets, your evidence-based targets. And we've seen how this plays out in the UK, where payment for performance has been around for years. For example, a mandate to prescribe ACE inhibitors for patients with hypertension led to a massive increase in admissions for acute renal failure in the older atherosclerotic patients. My British colleague, Roger Greenwood, who spoke here last year, labeled this condition guideline nephropathy. So how much time do I have left? Okay, good, all right. So the accountable care organizations are failing because they must fail. They're based on faulty assumptions, poor economics, and junk science. They wouldn't exist in a truly free market. They were just a product of government and crony capitalism. The quality benchmarks, as I said, are going to be these so-called guideline targets. Any money saved by rationing care, or let's even give them credit for improving care, which I don't do, but let's be generous, is going to be consumed by the incredibly increased administrative burden involved in these structures and whatever profit they're going to skim off, okay? So for them to succeed means that they're going to be taking money out of the system. They're based on the myth that fee-for-service medicine is responsible for the high cost of medical care. This is demonstrably false. It's the direct third-party payment system spearheaded by Medicare, which is the culprit, plus the massive expansion of the administrative sector that Paul Kempen told you about yesterday. And of course, when Uncle Sam's your partner, there's always the risk that the rules and payment will be changed, sometimes arbitrarily and without warning, as reported in modern healthcare. As ACOs grow more efficient and Medicare adjusts savings targets accordingly, it may also grow increasingly difficult for ACOs everywhere to earn savings. Furthermore, Medicare's ACOs programs so far have produced inconsistent results, some of which policy experts and ACO executives have blamed on how Medicare calculates how much ACOs potentially save the program. Recently, CMS announced that the initiative saved Medicare $817 million through 2013. Dozens of participants shared $445 million of that amount, but 3/4 of the ACOs saw nothing after failing to do sufficiently well against the financial benchmarks. So in other words, only a handful saw any real profit, and you can be sure that Medicare is going to alter their formula to not allow whatever they consider to be excessive profit going forward with this. And Kaiser Health News last month reports that Medicare paid $60 billion to 353 ACOs to take care of nearly 6 million beneficiaries. Patients at 45% of groups cost more than the government had projected based on historical costs. And after paying bonuses to the stronger performance, the ACO program resulted in a net loss of nearly $3 million to the Medicare Trust Fund. So, also, it's clear that for ACOs to be profitable, they're going to have to engage in the old HMO strategy of cherry-picking healthy patients. And so very sick patients are not going to do well in the ACO setting, and they will be avoided. The ACOs are going to try specifically to eliminate them. So you will see. So we have now arrived at the point where the government is not only paying for care, but they are dictating how care is provided. They're dictating what insurance companies can charge, what they must cover. It's a complete federal takeover of healthcare. And the only way you're going to be able to retain the autonomy to prescribe and take care of your patients as you see fit is by getting out. There's simply not going to be an option to remain independent if you stay with ICD-10, meaningful use, electronic health record, these payment for performance schemes that are coming at us. It's going to be impossible to ethically take care of your patients and stay within the system. It's going to get increasingly worse over the next several years. So now is the time to make your plans to get out. You have to create a financial picture where you can either cut down your practice, get out of these third-party contracts. They're all going to be the same. There won't be any good insurance contracts, okay? They're all going to be bad. So the only escape is through a cash-based practice or a concierge practice where you can control and not give out the information. You can maintain confidentiality of patient information. This is where we need to go, and if we don't do it now, the window will close. I'm convinced that the administration is going to make it illegal for doctors to opt out in the future. They're going to, so we have this opportunity now. We can create private practice. There are all these incredible models out there for direct patient care. There's Pager, that Katie was talking about yesterday, these web-based apps, these iPhone-based apps that deliver healthcare to your door. All this wonderful innovation is available now. If we don't take advantage of it, though, I'm convinced that it's going to be taken away from us at some point in the future, particularly if we have a continuation of the current left-wing cabal leading this country. So I'll take any questions.
Last year about this time, there was a report on the initial experiences with ACOs, and I don't remember the actual figures in my head right now, but I remember there were a significant number of the pioneer ACOs, or the original ones, had opted out.
About half of them opted out,
and
yes.
And then the other ACOs also, and they weren't doing well. A lot of them opted out.
Yep.
And in fact, the Mayo Clinic, Cleveland Clinic, and I think Kaiser, upon whom the idea was based, chose never to participate in it. Are there any updated numbers?
I just gave you the latest, which is from Kaiser Health News from this just a few weeks ago, where over 45% cost more than the government had projected. So they're failing. I mean, you would think that based on the pioneers that they would have said, this is not going to work. Let's go back to the drawing board and we'll come up with something better. They didn't. They're going full speed ahead. And Burwell says, not only are we going to push this in Medicare, but we're going to impose this on all insurance. right? The ACO model is what they have based their hopes on. And it's obviously failing now. Yeah.
Yeah, great summary and a great term as your president the past year. I'm worried about, I was heard in Massachusetts that they require all physicians to see a certain number of Medicaid per year. You cannot opt out of Medicaid. At least that used to be the case, as I was told. I'm not sure. But that's what I'm worried about. The state legislature is just going to say, okay, well, get her drunk one day and say, oh, we're just going to make everybody, all the doctors see Medicaid. You don't have a choice.
Well,
so how are we going to combat that?
I don't think that that's true. However, what the real danger is what Paul Kempen was talking about yesterday, which is the federal compact, the federal state medical board and the interstate compact, which is a prelude to a federal license to practice medicine. And once the feds control medical licensing, all bets are off. They can arbitrarily do whatever they want. No one is going to oppose them. We cannot count on the courts, obviously, to enforce state rights or enforce our rights. So at that point, they have complete control over the medical profession, which is why we oppose this, by the way. Yeah.
Call me cynical, but I don't think it's surprising that even though the ACOs are failing, that they're pushing full steam ahead. Because I really think the ACO, in a free market, hospitals come and go, and doctors' practices can come and go if you badly mismanage your practice. But in order to bring a single-party payer, you got to have a big reason. And I think the idea here is this is the Reichstag fire. I mean, we're going to have a forced economic collapse of all the systems in the United States, and then they're going to come and say, oh, look, guys, free markets don't work. We've been telling you that. Let's bring in Canadian-style universal health care. So actually, I think the ACOs are functioning exactly the way they wanted them. That's my cynical.
Well, we are merging everything towards one big payer as it is. I mean, the insurance companies are merging. They are under federal control. They are really no longer free, independent companies. They're really cartels that are run by the government. They're more like government-sponsored entities than actual private enterprise at this point. Yep.
Thank you, David Caleb from St. Pete. Just a great presentation. Just a little report from the field. I was recently ousted as an officer of the Florida Medical Association, a position I spent years building into, because I outed our fellow leaders for promoting ACOs. They were working with Texas, what's called the Practice Edge, to promote ACOs, bring it into Florida, make money off of ACOs. I also outed them on macro. Our policy said, no, you can't. But basically, the establishment medical organizations see this as a way to control, to make money, to be at the table, to rent seek and all of that. I would like to encourage our members that as we try to stay out of this as much as possible, that we tell the stories of our patients through the AAPS, through whatever means we have, that as patients are refugees from this system, they're getting hurt, that we find ways to tell the stories of our patients and how they're not getting the doctors they want, they can't get the care they want. Tell the stories of our doctors who have been forced out, good doctors. I think if we do that storytelling, that will be the best thing we can do to try to end this monstrosity.
Well, that plus we have to get out. We have to have a critical mass of opted out physicians who will oppose this system. We need a mass that's too big for them to put us all into jail. I mean, I don't know what number that is, but it's higher number than we're at now. I'm convinced of that.
Yeah, Daria Schooler from Indiana. I retired at the end of 2013 from my practice, and only after that, about a year ago, I said, well, I've got to end my Medicare contract relationship because I'm no longer actively practicing. So we got the form to disenroll, and it's really easy. It's a 40-page form, but you only have to fill out certain parts of it. And within 6 weeks, I got a letter from the Medicare office in Wisconsin for our area. It says, hey, congratulations, you're out. I'm like, yes. So it's a lot easier to disenroll and not be a part of all this opting out nonsense, so that you can have a direct doctor-patient relationship without having to deal with these
Great
monsters.
point. Thank you so much. One or two more, Jeremy. And of course, David, your point is that many people are ripping this system off. They're going to make tens of millions of dollars off these ACOs, and then they are going to get out. That's the plan, for sure.
Right.
Yeah.
I'm wondering, as a nephrologist, how do you plan to go cash?
Well, that's a tough one, and I'll talk to you about it afterwards if you like.
All right, we'll take one more.
Thank you. I'm wondering how these
people who project these budgets for whatever three-letter acronyms there are, HMOs, ACOs, they're basically the same. And we've shown that they always are more expensive than what private practice does. I mean, I see it in my little community. Whenever the hospital hires a new physician in their foundation health program, they close their practice after half a year or a year and take no more patients, and they're not staying there longer after 5 o'clock. Their volume goes down.
Absolutely.
And there is published data over and over that these people are not earning their salaries, basically.
for sure.
And the organizations who hire them complain that they actually have to subsidize them because what they actually bill is much less than what they're making. So how can this model be cost-saving?
It cannot be. It cannot be. The most efficient model is a direct pay model. It cuts out the middlemen. All these middlemen are ripping off the medical system for billions of dollars a year, and they contribute no value. So we have to go back to a direct pay model or we fail.